Good afternoon, everyone. Thank you so much for joining us for our community conversation this afternoon. I'm just going to give it another minute for everybody to get settled, get a glass of water, make sure their computer's all set up, and then we will get started in just a minute. All right. Why don't we go ahead and get started? So welcome, everyone. Thank you so much for joining us for NASW New Jersey's community conversation on social workers and misconceptions about opioid use disorder. I'd like to thank Rutgers University very much for sponsoring this community conversation, as well as Jamie Lister, PhD, MSW, who will be presenting this information for us. Now, before we get started, just a few housekeeping items. I just want to remind everyone to please keep your mics muted during the presentation just to reduce some of that background feedback we might get. And if you're having any technical issues at any point with the audio or visual, please feel free to leave the webinar and come back and we'll let you right back in and that may fix it. If you have any questions about the presentation, you can feel free to put those in the chat as Jamie is presenting. We will also provide plenty of time at the end of the presentation for you to ask your questions live and for us to have a more robust conversation about the information we just were discussing. So also want to remind everybody that when you registered for this program, you all signed a code of conduct. So we just want to remind everyone to please treat each other with respect and keep in mind that this presentation is being live streamed to Facebook as well as being recorded. And with that being said, the recording will be available to you all after. It'll be both on our Facebook page and on our YouTube page, and we'll have that available. I think that's all for my housekeeping. And so I'm going to turn it over to you, Jamie.
Thanks, Annie. And thanks to everyone for attending and to NASW New Jersey for inviting me to give this talk. As Annie mentioned, the focus today is going to be on social workers and misconceptions about opioid use disorder. Let's see if I can advance this screen. There we go. Okay. So our outline for the talk, first I just want to kind of go over the objectives of the conversation. Then we're going to do a little overview just of the ongoing challenges in the opioid epidemic. Then we'll drill down into some of the common misconceptions about opioid use disorder. And at the end, we'll focus on some next steps or solutions and then have an engaged discussion as a group. So the objective of the conversation really is just to encourage an engaged discussion about opioid use disorder. It's an important health condition for social workers to know about, but also one that has a lot of diverse opinions. And what I want to really get into is how some of these misconceptions that are common in the field relate to the scientific evidence and ways we can move our field forward. So some background on me. So I have kind of been a social worker through and through. I got my bachelor's in social work in 2002 from Miami University. I did my MSW at University of Michigan in 2005. And actually did my PhD in social work at Rutgers, finished in 2014. So I have experience both clinically and in research settings that are with other social workers, as well as professionals from different medical disciplines. Most of my research projects really take the goal to look at ways we can increase equity for addiction treatment access and opportunities. And it's important to me to disseminate the findings from research projects in events like this, like in trainings or to the news media, and really so health policymakers can see some of those things and make changes, or other systems can make changes. And then last, some of my work's informed by growing up in a health professional shortage community that's in rural Michigan, where a lack of access to services is common, but also misconceptions about addiction and opioid use disorder are very common. So the first thing I wanted to do, and I believe we created a poll for this one, was just kind of see how folks in the audience gather information, because there's lots of ways that we can get information about addiction or other health conditions, and really we need multiple forms. But if you can kind of look below at these options and reflect on, your day-to-day role, which of these do you use the most? So kind of option A is the knowledge you got about the scientific aspects of, addiction from your schooling or training. Option B would be practice or clinical wisdom that you've gained during your field work or other social work professional experiences. And option C is personal wisdom that you've had either from your own lived experience or other people in your social network. So you can just go through and say, this is about my balance and I really rely on this one most. And if you plop those answers in the poll, that might be nice to help us kind of see where people are orienting their perspectives from. And Annie or Jeff, if you want to let me know how I can see it, or try to see if I do see that poll anywhere. Oh, maybe I have to
Let's
answer
launch the poll.
Oh, okay. I'm going to answer it myself too.
Whenever, let me know when we'd like to close it, and then I can broadcast the results.
Oh, you know what? Yeah, keep it open for a few minutes then, Annie, and I'll move on forward. And maybe if you just want to bounce in at a spot you see, and then we can highlight it.
All right, and everyone can see the poll, right? If you can't, please let me know now in the chat or yes. All right, great. Thank you for confirming.
Okay. I'll say for me, I would have selected A, but most of my work is in the realm of doing research, writing research papers. So I think it's kind of imperative that I have to rely on that knowledge. But I think when I was in my more clinically focused roles, it was probably a balance of A, B, and C. I actually try to bring in B and C still to my research work, but it's perhaps less common than some of the scientific background. Okay. Let's see if I can. There we go. Oops. Here we go. So let's take a few minutes first to kind of look back at the opioid epidemic, kind of how it's going. And actually, there's an update out today, not a somber update, but something I'll include on one of these slides. So, there's initially, a few years back, people talked about the 3 waves of the opioid overdose epidemic. Now I think we're starting to see really that we're in a 4th. If you look at this chart, you can see kind of right around the turn of the century, rates of prescription opioids related deaths started to increase. So that's that black line. Then about a decade later, that blue line, heroin-related deaths started to increase, whereas the prescription deaths had started to flatten out a little bit. About 8 years ago, 2013 or so, synthetic opioid deaths, specifically to fentanyl, really skyrocketed, and you can see that kind of brown maroon line really taking off. And then in the last 5 years or so, we've started to see that yellow line of illicit stimulants, cocaine, methamphetamines, starting to be involved in a much greater number of deaths. So this gives us kind of a lay of the land of how this has been shaping, that it's not one single story, but it's been evolving over time. Some numbers just about the epidemic. In this infographic is a nice way to kind of see it. Some of the things that jump out to me: in 2019, over 70,000 people dying from a drug overdose. Then you have about 50,000 of those folks here on this bottom left column from deaths from synthetic opioids other than methadone, about 15,000 from heroin. But this just shows you kind of the burden or the impact nationally from the epidemic. However, just today, news stories about 30 minutes before this talk were running. So I grabbed this because I think it's important. So the newest estimates have just come out. And if you recall, we flashed back 70,000 people here. This is 2019. Now we're over 100,000 post-pandemic, right? So in the pandemic, there's been about a 30% increase in overdose deaths. The only caveat of, I don't want to call it good news, but is that New Jersey actually saw a 1% decrease. I mean, they still have a very high rate of deaths, but at least in the state, some of this surge didn't happen for us. Now we plateaued at a high rate, but so this epidemic continues to evolve and strengthen in many ways. This is a map of kind of the national impact of drug overdose death rates. This is 2019 data. they put these out every year. A lot of times the maps are pretty similar from year to year. But you can see on the left, any of the states with the darker color are states that have higher age-adjusted death rates. So these are looking at how many people per capita are dying in these states. And as you can see, I'm not sure, Annie, can you see me when I hover like this with the mouse?
Yes, I can.
Oh, all right. So I've got a pointer. So if you can see, New Jersey's here, we're in this third category of color, but we're still in a category that's above the average. So we're in kind of a high risk state, right? But look next to us. I mean, here's Pennsylvania, 5th, Delaware, 2nd, West Virginia, not too far away, 1st, Maryland, 4th, right? So this entire region, the mid-Atlantic, South Atlantic, have been hard hit. And for the most part, there's also been kind of a dividing line along the Mississippi River, kind of here in the middle of the country, where disproportionately death rates have been higher on our side of the country, in large part, I think, due to population density and access to synthetic opioids and stimulants. And this column on the right gives you that breakdown. And here's Jersey. I think we were 1, 2, 3, 4, 5, 6, 7, 8, 10. So we were 10th of all 50 states in the highest death rates. And we, in prior years, had been ranked even higher. But so obviously the epidemic here locally is still of a very strong concern. Okay. So, hey, Annie, do you want to flash back to what we had for that first poll question?
Sure. So these are the results of the poll.
Oh, I love it. Okay, so we got a nice, since I am in, research here, we have a decent kind of distribution of these answers, right? We're not all lumped in one spot. But we had, roughly half of folks who answered saying that their schooling or training after their degrees, at CE events is really what they rely on most. A third of folks saying that it's kind of that professional experience that's informing their decision-making most. And then 1 in 5 saying that really the things they've went through themselves or that their family and friends have went through. And, I think with addiction, really you need all three, right? This has touched everybody professionally and personally by this point. I think it's important that we draw on each, but then kind of are aware of where our perspectives are coming from. If, say, internally, when you took this one, you knew, hey, I'm all on this one. It's everybody has their own choice on how they choose it, but it's just something to reflect upon that, hey, I'm really relying on one and the other two I don't care so much about. At least for me, I've tried to balance them and use them in the situations they're needed, but not kind of go all in on one and not on another. Okay, so that's our option 1, and I can wait for our poll question 2 until a little bit later. Okay. So before we go into the misconceptions, what I wanted to do was kind of do some questions and answers just to kind of see where we're at with some of this, because these answers might help us see some of the misconceptions. Okay. So below there's 5 types of treatment services. And really the question is, which of these has the strongest research support? So meaning when there's a comparison of, treatment A versus treatment B, which one helps clients with opioid use disorder have longer periods of abstinence and have a lower risk of dying from overdose or just having a non-fatal overdose? So our option A are what are called opioid agonist treatments. That's methadone or buprenorphine. And when I say maintenance, that means someone who's, started on these medications, reached a period of stabilization, and then kept on the medications as a form of maintenance treatment while they get other psychosocial services. Option B is naltrexone, which sometimes you hear it called Vivitrol, Revia. That's an extended release injectable medication that folks get that's also FDA approved, but it is not the same kind of medication as option A. Option C is psychosocial treatment. So whether this is seeing a social worker or another health professional for individual therapy or group therapy. Option D is any type of self-help meetings, for example, 12-step, Narcotics Anonymous, maybe Smart Recovery. And option E is detoxification treatment, or not treatment, but detoxification or withdrawal management, where folks go in and have kind of a medically supervised detox from opioids. So let's, what I think we'll do first is, can you hit us with that poll question? Let's see what we had before we get the answer.
Sure. So everyone had answered all three questions. So I'm going to show you
Number two.
Yes, number two. So I'm going to share those results and you should be able to
Right,
scroll down and
nice.
see those.
All right, so we have a spread, and so this is nice. This gives us kind of two stories. So on one hand, I'll say that the attendees on average got the correct answer. But on the other hand, it shows us the diversity of views about not what someone might prefer, but what the evidence supports. So obviously, from client to client, people have different preferences. But the research support, let's jump ahead to mine. There we go. Can you see that bolded there, Annie?
Yes.
Okay, so the research report's pretty clear that methadone or buprenorphine maintenance treatment are superior in terms of promoting abstinence and helping prevent future overdoses. And we have a slide that I will show next here. See if I can read that one. Okay, so what these lines show you are kind of the number of relapses for different types of treatment. So the blue line is buprenorphine, which you may hear of called Suboxone, Subutex. The red line is methadone, which you can only receive methadone, at least generally speaking, until some policy changes occur. Receive that at opioid treatment programs. I believe in the state of New Jersey, there's roughly 40, so you don't have too many. Maybe on average 2 per county, so it's hard to access. And that green line is behavioral health treatment. So we're talking about psychosocial services, counseling, therapy. So you can see that the red and the blue lines are much lower, which means relapses are less common in those approaches. Versus that green line at top, you have a really high rate of relapse in the early periods of treatment with behavioral care. And one argument can be made a lot of times that behavioral care helps more in the long term, that it's more lasting. You do see that behavioral treatments, the longer they go out, it does help, but even at the far out end, they never approach the effectiveness of the medication treatments in terms of preventing relapse. So let's go back to the other options on that slide, because that was what we had there, I think, was options A and C. I don't have a chart for another paper, but these other options, naltrexone, detox, self-help, are compared in a paper that was in JAMA, which is a large medical journal, just came out maybe a year or two ago. And it's the same pattern that methadone and buprenorphine are superior at promoting positive outcomes for clients versus all the others. We might get into detox a little bit more later, but technically speaking, detoxification is not a form of treatment. It can be kind of a bridge to treatment if folks are offered detoxification and then transferred to treatment, but that's not necessarily that common. A lot of times, clients are provided detox under the assumption that when the physical dependence or the physiological dependence is gone, that will solve the addiction. Unfortunately, what it can actually do is promote a greater risk of overdose death in the near future, because tolerance to opioids has gone away. So while there is some benefits to it, largely if people can get linked to more formalized care, there's actually some risks to it as well. Self-help meetings are a little tough because it's hard to study self-help meetings. A lot of times, in papers, there's not as much control, so to speak, in the research design because of meetings being closed or not necessarily partnering with the research groups. But the studies out there that do look at self-help have found both self-help and psychosocial care have found potentially an added bonus when applied on top of methadone or buprenorphine treatment, so meaning you get both. But there's actually a large movement in the field now called medication first treatment, because what happens a lot is people believe you have to have both. And so if a provider says, I can do buprenorphine, but no one here can do the psychosocial, they won't even provide buprenorphine to the client. But the literature actually suggests that the decision in that circumstance would be to provide the buprenorphine because it's effective. And if and when you can find psychosocial care, that's great, but you shouldn't always tie them together, because what that effectively does is reduce access to option A. And naltrexone has shown some, some strength, but it's not as effective as methadone and buprenorphine. Okay. And you can see for a lot of these, I've included the citations in the bottom. I'm going to share with Annie and Jeff the slides at the end, and they can distribute those out to you, as well as they might have a link to a reading as well. Okay, so option 3, or not option 3, sorry, question 3. So from the terms below, which of these, when used to describe a client, so taking note, that's not saying I self-identify as this term. Which of these have demonstrated in research studies to increase stigma or biases about addiction? And this one, you could select all that apply. I'm not sure if our poll was able to do that. But Annie, if you want to bring up our poll results, and then I'll flash to the next page. Okay, interesting. So this is, I'm have to take a second on this one. So let me show the answers, and then we can look at the, let's see if I can get my, oops. I'm having a little struggle getting to advance at times. Oh, here we go. Okay. So actually it's options A, B, and C. Folks overwhelmingly selected option C. So that one is in line with it. But actually there was not a real strong agreement among the attendees about the other options. And if anything, option D was selected a little bit more often. So let me run through these and kind of why each one may be considered stigmatizing or harmful. So option A is probably the most confusing one, because we still have many treatment facilities called substance abuse treatment facilities, right? So there's two reasons that this is an outdated term. One is that DSM-5 came out in 2013, and at that time removed both the use of abuse and dependence as diagnostic categories, and at the time switched to substance use disorder. So specific versions of those disorders include things like opioid use disorder, alcohol use disorder. So terms like alcohol abuse are considered outdated. Now that's just kind of a diagnostic terminology, but the reason is that abuse as a term connotes criminality, right? So when you abuse something, when they do studies looking at, you present a vignette and you say, this is Joe, this is his life story, here's what he does, he abuses drugs. Then you present the same story and say, this is Joe, he sometimes has drug misuse. What happens is that when people read option A, and then they're asked questions about Joe's reliability, character, criminal characteristics, they rate him worse when the term abuse is used. So that term has been frowned upon because it can reinforce negative views about the character or morality of people with addiction. A drug user and addict are both stigmatizing because they're not person-centered language. Right, so when you say drug user, you connote that the entirety of that person's humanity is about their drug use, as opposed to a person who uses drugs, right? So there's option E. Person who uses drugs suggests first and foremost, this is a person. One characteristic is that they use drugs, right? Drug user says that's who the person is. An addict is a tricky one, because it's the same thing where it connotes that the person themselves is only a quote unquote addict and not anything different than that. But within the recovery community or people that have lived experience, it's very common for people to say, I'm an addict, I'm in recovery. So it is important to understand the difference, that I would not be encouraging anyone to tell a client to not self-identify in any particular way. But for us in clinical notes or in professional discussions, saying, I have a client who has addiction, is a different a different message than saying, I have a client who's an addict, or I work with an addict, right? They send off different messages. And there's lots of, as another just kind of caveat on this, there are lots of journals now, professional journals, that will not even allow a paper to be submitted using any of these terms, right? It's, I think it's something that, like, the fields of health and social work are going through a reckoning in a lot of ways about terms that have been used for a long time and are common, but that are not helpful, and if anything can be harmful. So this is similar to the things we've seen in other ways about ways we describe people. Oh, our last one. No, I think I have two more actually, so I better go through them quickly. So these two statements, whether or not they are true or false, since they're not up in the poll questions, I'm going to give people just, 30 seconds or so to read through this. And I'm going to advance us, even if you're still going, they're going to be on this next screen. Okay. So both of these statements are true. So approximately 90% of people who undergo medically managed opioid withdrawal, or what we would call detox, have a relapse within 1 year. So that shows you the idea that to get somebody to not have the physiological dependence alone, maybe that works for 10% of people. The other 90% of people, it's very dangerous, because if you give somebody a greater risk of relapse and they're not linked to other care, that can be fatal. People linked to MAT following detox are less likely to die from an overdose. And the second question, or the second statement, so when people stop using opioids abruptly, whether this is detox or just stopping use on their own, they lose tolerance. So they're kind of, the tolerance they've built up over months, years of use goes away. What happens then is if they relapse and use a similar amount, or they have fentanyl mixed in, the tolerance is down, which greatly increases their chances to die when that relapse occurs. And our last one, what does the American Society of Addiction Medicine definition of addiction have in common with the CDC's definition for diabetes, heart disease, and cancer? They're all chronic diseases, right? So that's what's in common. So now we've kind of laid the land of some of the things I think that underlie these misconceptions. So let's look at these misconceptions specifically. Okay. So for me, and this is just the way I'm organizing them, there's three kind of common groups of misconceptions that I've observed in social work as a field. The first are biological and medical misconceptions. The second is research evidence misconceptions. And the third are the stigma and biases about addiction. So let's knock out the first one. So kind of as some background, I mean, I'm sympathetic to it as someone who's went through social work programming, some of it including very little attention to addiction. It's uncommon for social workers as students to receive much training on the biology behind addiction. So to learn about tolerance, physiological dependence, craving, withdrawal, we don't get coursework on that. We might have a little bit, but nothing compared to somebody who some other disciplines that have a bit more medical focus. Similarly, it's entirely uncommon for our coursework to review things like induction onto buprenorphine or methadone, when does stabilization occur, and what does maintenance treatment look like. So often what you hear is someone say, so-and-so was treated with buprenorphine, but really what happened was they might have went through detox, right? So they never were inducted, stabilized, and maintained. Though it's definitely common that folks are getting more of this exposure in their field work. And as a result, it's not surprising that our field has a lot of misconceptions about the biology and medical processes underlying addiction. Next up, we have our research evidence misconceptions. So while research courses are required during BSW and MSW degrees, it's uncommon to have a dedicated research period. So for myself, In the years it took me to get my BSW and MSW, there was very little focus on research outside of a course or two here and there. I wasn't doing independent studies, writing research papers, or really reading and digesting literature, talking about it in depth with colleagues or supervisors. That didn't happen until my PhD. So I think that places an unnecessary burden or an unrealistic burden on most folks to really have time to learn all the terminology that's in a research paper, let alone once they're in practice to stay engaged with that as the research is changing. There's everything I ever hear is I have too little time. So with all the other responsibilities to kind of stay up to speed on research is challenging. And I think one thing that's key is that, social workers deliver behavioral care. That's what we get trained in, right? When we go through clinical classes or case management classes, it's all about what we can do with kind of non-medication human services. So it's not surprising to me that our field would have more familiarity there. But that may lead to people having a preference over medications and kind of conflating that preference with whether or not the research evidence suggests that it's more effective. Whereas the research evidence, as we reviewed before, shows that it is not. This is just some brief kind of medical components. So, there are 3 FDA-approved meds for opioid use disorder. We've talked about methadone and buprenorphine, a little bit about naltrexone. There's some of the brand names in parentheses. In this article by Sarah Wakeman, looked at kind of all the treatments compared against each other. And this journal it's in is about as, competitive as it can get, and found that methadone and buprenorphine maintenance treatment are not only considered the gold standard by the World Health Organization, American Society of Addiction Medicine, and the National Institute on Drug Abuse, but they buffer mortality, meaning people die less often. They reduce relapse, and they retain patients in care better than naltrexone, detox, behavioral care, or 12-step. So this one kind of, in many ways, answered that question firmly, that of all these options, these ones are here and here, and the others are not as effective. So
we
now
did
let's
have a
look
question from,
yeah.
I'm sorry to interrupt. We did have a question from Facebook about methadone and buprenorphine, if you could answer. So they had asked if there were any other drug addictions that could benefit from those interventions, like can an alcoholic benefit from this, or perhaps someone who abuses cocaine, or is it just opioids and opiates?
So buprenorphine is, naltrexone is approved for use in alcohol use disorder. So you'll see that commonly used. Sometimes they have different names, but there's also other medications like acompressate that are used in addiction medication treatment. Right now, probably the biggest challenge is that cocaine use disorder has really harmful consequences to clients and to communities, but there's not any approved medications. But the National Institutes of Health has put out a bunch of money and calls for these kind of solutions. So far, I think there is some promise with some medications that, maybe in 5 years, 10 years, I have to look at them specifically to see, but maybe eventually there's medications that are more commonly used there. But, I think that's a great point, because in some of where maybe the uncertainty lies as a social worker is that for this type of addiction, I use medications first. For this type of addiction, I don't, right? I do think that's one thing that the field of social work, in my estimation, needs to improve upon, is that we often talk about addiction and substance use as kind of a one-size-fits-all, but they're definitively not. In the same way, we would not think that someone with post-traumatic stress disorder and obsessive compulsive disorder have the same treatment needs. Someone with opioid use disorder and cannabis use disorder should not be receiving the same types of interventions. So I think the first thing I would encourage everyone to do is look at best practices for each addiction separately. And that question really highlights that kind of, what are the medications for these? And unfortunately, the answer to that is that they're not as widely, the evidence is not as strong for other types of addiction. Parts of this is that what methadone and buprenorphine do is they come in and kind of replace the opioid of misuse. And so folks don't have to go through the same withdrawal and craving. And also when someone uses opioids or heroin, it kind of blocks or blunts the effect. So some of it is just these medication replacements work in that type of addiction model better than they do for other substances.
Thank you for answering that so thoroughly.
Yeah, thanks for the question. Let me see if I can. There we go. Okay. So this is my favorite one of the three because I just think it's so important, and you're seeing so much about stigma now. But really, I think I don't want to put this all on social workers, right? I mean, as a society, we do a pretty poor job talking about addiction. They're common. People have lots of negative views. Maybe the opioid epidemic has helped crystallize to a degree that addiction is a chronic health disease, though I think there's some weaknesses in the fact that it took it occurring in middle America a bit more for people to recognize that. It's not like addiction started 10 years ago. So, and even though we as a field have more training than the public, it's still really common for you to hear these types of views that I'm going to show on the next page at your agencies, your classmates, your professors. So let's just think about these. And I put these in quotes because I don't like the terms, but would you ever call a person with heart disease a heart diseaser? No, but I've definitely heard someone with a substance use disorder called a substance abuser. Would you ever say a person with diabetes isn't in recovery because they use an insulin pump? No, I wouldn't, but I've definitely heard people say someone with an addiction isn't in recovery because they're taking buprenorphine. Would you recommend a person with breast cancer only seek counseling because social work staff at the agency are concerned that the medications will actually be a hindrance to their recovery? Absolutely not. You would say you should see an oncology social worker as well as drug therapies and consider other treatment options that all can help. And last, would treatment systems refuse to hire a candidate as an oncology social worker if they were receiving treatment for cancer themselves? No, we would probably see that as a strength. But on the flip side, I know of agencies that strictly disallow people from working at those facilities if they have urine drug screens positive for these medications. Even when they can show that those medications are being used under prescription, there's still enough stigma about them using them illicitly, even though the research data suggests it's highly uncommon. So those are things to think about. If you catch yourself or other people, always reflect back. I like heart disease, diabetes, and cancer, because these are ones that I think, I don't know the stigma literature on those, but my impression is they're much different. So our next steps, and these are my last things before our Q&A. So what can we do? Individually, system-wide, field-wide, what can we do? I think the first thing is we can always get more training, more knowledge to help increase, make this situation better, but specifically to help clients who want access to these medications be able to get them. So the training might be, learning about how the induction phases, stabilization, what that is, so that you can give accurate information when clients are interested. It may be connecting with other agencies or facilities to learn about it, talking to your agency about kind of the evidence-based ways to do it. This one, I think if you want to make change, you really can reach back out or encourage your training institutions, so where you got your degrees from. So for me, this would be University of Michigan. When they call and ask me for alumni money, I can say, I'll give some money if you dedicate more programming to addiction, but no, really just in a survey about what could be done better. I think generally speaking, very few social work programs focus on addiction. Rutgers actually does a good job compared to most. I'm happy to be a part of their addiction counselor training certificate, but we can always do better. And I think many social work programs, even when they try to teach about addiction, foster some of these misconceptions. They may not mean to or intend to, but so you hear it from your professor or the trainer, you walk out thinking that's what it is, but it may actually be more harmful than helpful. I think we can improve our own culture by using non-stigmatizing terms, person-first language. And when hearing someone present some of these pseudoscientific views about addiction or medications, we can have a polite counter argument back to try to not let that kind of just continue to dominate, because Right now, there's a lot of initiatives to try to change stigma and views about addiction that are quote unquote top-down strategies, right? Have kind of large agencies tell us what are the ways to think. My view is that there's still a big need for bottom-up changes, that people working at agencies themselves, more local groups, have to kind of create these changes internally, even if they just create it at their own agency. That's a humongous benefit to the people in that system. Another idea is, and I know everyone has a lot of responsibilities, so I would suggest maybe once a month, 1 hour, I don't know, but start a journal club where you say, hey, somebody spend an hour, find the newest, coolest, most exciting article about addiction treatment and send it around, and we'll go have lunch. And I mean, you can even divvy it up. You read the introduction, you read the methods, you read the discussion, and just talk about it. I mean, it sounds kind of dorky, I guess, but you know, on the flip side, this is a way to stay engaged when, if and when your responsibilities are demanding. And the last steps here, it's just pivotal to identify the practitioners that are providing buprenorphine or the methadone clinics or opioid treatment programs. There's a lot of limitations at those facilities on how many patients they can take. There's more demand than there is supply. And so the more that you can partner and say, hey, if you're able to start this patient on this medication, we'll do all the rest, right? That can offset concerns from the provider that I'm not going to be able to adequately handle everything this client needs. You say, well, we'll partner with you. We'll provide the trauma therapy. We'll provide the other case management services. We just need somebody who prescribes this medication. The other option is to try to get folks within your own facility waivered to provide these medications more. I'm involved with a project that's doing that, and some health clinics to try to train people to provide buprenorphine there as opposed to refer out. Be an open collaborator when coordinating with people that aren't social workers, you know, that you kind of know that they've got some of these biological and medical knowledge that maybe we don't as commonly, but that you're open and receptive. Really think one way you can serve clients and communities is by making relationships with, you know, kind of the higher up, so to speak, the treatment regulators and health systems directors that you work with, and advocacy groups to try to make change. And last thought is just to pursue or join any kind of funding initiatives. If you hear of something, there's so much money out there to improve agencies and to improve treatment from HRSA, from SAMHSA, you know, and lots of times these are required to be led by the agency themselves. So if you can figure out somebody that can write that proposal, or you can partner with someone who can, you might be able to roll out some new exciting program in your setting to help your client base. And that's the last one for me. I'm going to jump it here. There's my email, and I'll turn it over to Annie and Jeff.
Thank you so much, Jamie, for that presentation. Everyone, I want to encourage you to put any comments or questions you may have in the chat, and then also you can feel free to raise your hand and we can unmute you if you want to ask your question live. I see we do have one question in the chat. Someone said it's encouraging to see the state requires at least one CEU on opioids for licensed social workers to address some of these knowledge gaps, but there still seems to be a lack of training and professional development opportunities. Where can we look to not only satisfy that requirement, but also learn some more in-depth information beyond the general awareness?
It's a good question. And I actually know that audience member, so I appreciate the question. I would say, where can you look to get more professional development opportunities? You know, I think events like, NASW the other day, I know had a big CEU event on the drug policy team and ending the drug war. I'm sure that they would be aware of other options. You know, maybe that if you can look for opportunities that are, you know, not necessarily just through the state of New Jersey, if they're still eligible for CEs, where you can go with more tried and true kind of addiction and substance use groups. I think that the danger sometimes if you go just to a social work CE is that how much time are they really giving to addiction? More than they used to. But so to try to see if you can find things that maybe is cross-listed, so to speak, where there's some social work credits, but it's maybe not led by social work, they might have more of a priority. And I think one thing that people can do too is, even if you're out in the field, I still think auditing courses or taking online webinars from SAMHSA or things like this, they're free. You can join in on one and learn, in an hour, kind of the nuts and bolts of medication treatment and say, now I've got that in my toolbox. I don't need a CE for it, but if I get one, great. Maybe there's some webinars that SAMHSA is offering that I'm sure that they are CE eligible.
Thanks for sharing those resources. Yeah, we had a 6-credit CEU on the decriminalization of drugs in New Jersey just last week, which was a great program. And we also frequently do a program on opioid use disorder and the history of the opioid crisis in New Jersey pretty frequently in NASW. So I can put a link to our next one in the chat as well. Great. We have another question. Have you viewed any of the new shows such as Dope Sick on Hulu? It's about Big Pharma and the OxyContin outbreak in a small mining town. I don't know if you've seen it. I think that's more of a comment, but
I have not watched it, but that's partially on purpose. So I would say my general impression of the way that media and film cover opioids is sometimes they do it well. They all unfortunately, like the show Euphoria had a big scene with a person who's the main character who had addiction history, and they did a good job in some ways of showing what it was like to live through that addiction. They used lots of negative terms and had lots of kind of views and biases about addiction that I do think it was realistic about the way people talk about it, maybe with a sponsor, but it felt to me a little bit dangerous to make it seem like that was the way that all of us should view someone with addiction. Is kind of, they might have said you're a loser, like things like this. I can't remember the words, but the Dope Sick show and the Big Pharma critique, my only problem with it is that I think it's an easy answer that really who to blame for the opioid epidemic is Big Pharma. But the reality is heroin use disorder is well preceded the timeline of Big Pharma. A different type of opioid epidemic occurred afterwards that escalated the scale of problem and maybe the types of communities that were affected. But I mean, I used to do a lot of research in Detroit. And I mean, one common theme we would hear was just that people said, this epidemic of drugs and heroin and cocaine has been around in our community for a long time. So this idea that now all of a sudden it's epidemic is a little bit kind of disconcerting or hurtful to hear. But I think at the same time, it's true that Big Pharma did potentially kind of push it to another level. So it's both. But the show itself, no, I have not seen. But if it is in a small mining town, that does touch into some of my passion, which is growing up in a rural area and knowing how commonly folks there deal with opioid use disorder. And really the major thing for them is that there's just no treatment anywhere nearby. People in urban areas have considerable treatment obstacles too to overcome, but both of them are in shapes where there needs improvements.
Thank you. And I know I put the link for our NASW presentation on prescription opioid misuse, and our presenter talks a lot about, the full history of the epidemic and how this introduction of Big Pharma does also have some suggestions on some of the racist history and how we've kind of rebranded the opioid crisis. So it's interesting that you comment on that. I see, Jacob, you have your hand raised if you'd like to unmute and ask your question.
Hey, thank you so much for the presentation.
Yeah.
I was kind of curious, how long do you think people, and I know it's like obviously very individualized, but if someone's on buprenorphine, is it usually like for the first year and then you help them wean them off of it? Or is it like 2 years? Is there like a general time frame that people should stay on it to help prevent relapse?
That's a great question. I think that, there are kind of practice guidelines or maybe best practices that with buprenorphine, you'll hear that kind of year timeline, 6-month timeline. In the methadone clinic I used to partner with in Detroit, kind of 1 year was often a cut point of like, did somebody stay in treatment for a year, meaning that there was not an expectation of them, scaling back their methadone dose prior to that. But I also think that it's, driven by the client in the sense that some folks in that methadone clinic had been maintained on methadone for a number of years, and hadn't had any relapses in, a number of years, but were not comfortable stepping off the methadone because they believed firmly that that was the thing that had changed their addiction. And they said, I'll deal with the side effects, or I'll deal with having to come to the clinic more than I want, as opposed to risking myself slipping back. But then there might be another person who after a year says, I really feel ready. I think that typically that's something that should be a discourse between the provider and the other allied providers too, right? Folks that might say, hey, we want to support you in this journey, but we're concerned that this slip could occur if you go too soon. But yeah, it's a sustained period though. I think that's the big point that Jacob brings up, is that it's not something that someone is going to get substantial gains from if they're on it for a month, right? Or a week. I think generally speaking, you don't hear someone saying less than 6 months is going to be therapeutic. But of course, there are downsides of, say, you were never offered to go off it or never told that, and it was multiple years. But my experience with consumers is that they're aware of it. They have other friends who've started, stopped, tried. So I think people know about that and can advocate, so long as the providers themselves aren't kind of resisting that choice.
Thank you. And we have a few questions in the chat that really go along with this conversation that we're having, including, so you had mentioned, as long as the provider is having that conversation, is that a common conversation that's happening? Is this something commonly discussed with people when considering their options, this concern about dependence, that they may have on these medications? And then going along with that, how can we lead clients to self-help groups and different recovery models that are more accepting of this? Because as a clinician had said that clients on medication-assisted recovery have really felt ostracized relating to using substances.
Oh, absolutely. And that's a great question. So I'm going to try to tackle the first part first about the self-help groups. And then maybe if I might need a reminder of the first part. But yeah, that's totally true, that many self-help groups believe that using, a medication that is mind-altering, even under prescription, is not consistent with the goals of the community. But that's not the case for all groups, right? There's different groups. So I think it's harder to find a group perhaps, but there are a lot of groups. So it might take a little more time to find it. But I think absolutely if somebody goes in, there's lots of times clients in the methadone clinic would say, I do go to this NA group, but I don't tell people that I'm in the methadone clinic, because if they find out, they'll tell me I'm not in recovery. I've got 0 days. Now at least the opioid treatment programs are generally required to provide some type of therapy or group therapy. So in our clinic in Detroit, there was a 12-step facilitated group therapy sessions that clients had to attend, a certain number of them, per week or per month. And those were essentially 12-step principles with acceptance about medications, but facilitated by a clinician at the facility. So that was kind of a model where they got a little bit of both, but that 12-step effort was kind of happening within the clinic as opposed to outside. And the first part I think was about dependence. Is that right, Annie? Like dependence on the medications?
Yeah. So the concern about, let me go back and read it. But, that someone had said that they know people in recovery have chosen not to use Suboxone or methadone due to concerns about the dependence. And so they were just curious about, is this properly communicated, and are different options discussed with those who may be considering this because of the concern about longer period of withdrawal symptoms? And
yeah, I mean, I think that one thing that's important to communicate if we're social workers in this role, and let's say a client is asking us about this, is the difference between physiological dependence and addiction, right? You can be physiologically dependent on the medication, but taking it under doctor or practitioner prescription, which would not classify as an addictive behavior, right? Because addiction, you're not doing it as a part of your recovery effort. So I think that's one thing is to clarify, because I still think there's a lot of stigma about using the medications and thinking am I addicted to it? I'd say physiologically dependent, yes. And yeah, I do think at least the clinics I've worked with, they have had a lot of conversations about concerns. I think they used to call it like withdrawal phobia, of when folks would go off the methadone, the anxiety that they had that if I go off this, I will immediately relapse, and all the things that I've worked so hard to kind of put, as something that's not occurring now will come right back. So I at least there, I would say that they were upfront and honest about the fact that this, while this medication treatment works well, there is this process with it that if you do want to go off in the future, you'll have to do it in a graded manner under supervision so that you don't go off too quick. And it will take some time. Generally, what my impression was is that when people had hit a point where other treatment approaches hadn't worked, their belief was that the impact of the medication treatment was worth some of those side effects. But of course, if you could get rid of those and you could just have somebody say, I don't want to use it anymore and go off it and no side effects, I think that would be great, but that's not how it is. So I do think it's a nuanced conversation that I think is a common conversation in clinics, but perhaps less common if someone's receiving it at an outpatient family medicine doctor and getting Suboxone, where maybe that provider is not so familiar with all of those things as, say, someone at an opioid treatment program where everybody is dealing with this all day.
Thank you for answering those questions. And one last question, since I know we are short on time and I want to be respectful of everyone's time, but to bring it more to macro and advocacy, there's some recent bills introduced in Trenton that would address the needs of individuals struggling with opioid use disorder. For example, one that authorized expanded provision of harm reduction services to distribute sterile syringes and provide certain support services for persons who use drugs intravenously. And then there's another that requires certain health insurers to provide coverage for counseling and behavioral therapies for any person receiving medication-assisted treatment. Are you aware of these bills? And if so, are there efforts that social workers should support, and how can they get involved?
I've heard of them. I'm not, kind of steeped in them, but I think that the harm reduction bill is from my personal stake, is a win. There's obviously views and misconceptions about harm reduction approaches and people concerned that they will lead to more problems. But I think the science is supportive of the pros outweighing the cons for things like, clean syringe exchange and other harm reduction approaches like, testing strips. So I think that, for me, they're consistent with social work ethics in terms of allowing the client or the person to self-determine their own recovery as opposed to having to, or not recovery, self-determine wherever they're at. Right, that's I think kind of the message there. Then the other one you said, the counseling, that would be great, because one of the big issues, like I mentioned before, is that somebody comes in, wants to get started on Suboxone, and the office-based provider says, hey, you've told me you also have a history of X, Y, and Z. I don't do that here. And so then they try to coordinate, well, where do I get you set up? Well, my insurance is such, so the only place I can go is here, and they don't work with this, right? There's all these barriers. Now, if all of a sudden there was kind of guaranteed coverage for mental health, presumably that would open up a much greater network of places that folks could see mental health providers, and now all of a sudden they could communicate that to the buprenorphine provider, or perhaps the buprenorphine provider would just know, say, well, why don't you're now eligible for this, so now my concerns have been addressed. Because that's one of the biggest barriers to doctors and practitioners giving Suboxone is that they don't feel they can holistically treat the client's needs, and that people with opioid use disorder have complex needs. And so they refer people to the methadone clinics. But like I said, in Jersey, even a big populated state, we only have 40. So now you're asking someone to travel long distances multiple days a week. It's not going to happen.
Well, thank you. And I appreciate your insight on those two bills that, sound like they are in line with our social work ethics. And I know that it is 1 p.m. So I do want to start to wrap this up. Do you have any final thoughts or final comments you want to make about this topic?
I'm trying to see if I saw a comment about smart recovery. That would be great. If I don't know, who has which services at which, but I think it's anytime partnering some of these movements together, I think is wonderful. That's one of the biggest things I think we as a field can do. We know so much about all these other services that can accompany medication treatment, but it's really up to us to kind of help deal with this fragmentation. So we have to learn the other side of it that we don't get trained on, but then bring what we know well. And that's really going to give people the best chance to have kind of a comprehensive recovery.
Well, thank you so much, Jamie, and thank you again to Rutgers for sponsoring this conversation. As you all see, Jamie's email is on the screen if you have any additional questions, and this recording will be available on our YouTube shortly after. So once again, thank you everyone for joining us here today, and I hope you all have a great day.